Hello everyone, welcome to the Zoom meeting. So today we're gonna have our agenda. Let's share the screen for the agenda for today. And so we go. When are ready, this agenda, and then the first Amal, I hand it to you. Thank you.
Thank you so much, Dr. Nader. Hello, everyone. Thank you so much for joining us on today's presentation. My name is Amal, and I'm going to lead today's meeting on behalf of my great team. So we are going to start with stroke and cerebrovascular diseases, and our first presenter for today is going to be Dr. Abdelwahab. Dr. Abdelwahab, if you are ready, just let me know so I can share my screen for you. I'm not sure if Dr. Abdelwahab joined or not.
We can, if we have the other presenter is ready, maybe we can switch the items.
We can, Dr. Hello, everyone. Dr. Amal, if you are ready, we can start with our project if everyone.
Okay, sure. So the second presentation is going to be about evidence-based practice. It's going to be presented by Dr. Marwa and myself. So I'm going to start by talking about background, history, and steps used to implement evidence-based medicine into our practice. And Dr. Marwa is going to walk us through the best evidence available resources that we can use. So let me share my screen. So as doctors practicing medicine, we cannot depend only on the knowledge that we have gained during medical school or during our residency. We have to always search for the best evidence so we can find the best solutions for, of course, together with our patients. So let me talk a little bit about the history of evidence-based practice. So it all started in 1972 when Professor Archie Cochrane, who is a medical doctor and researcher in the UK, highlighted the fact that most treatment-related decisions were not based on a systematic review of clinical evidence. So he noticed that doctors at that time were depending on their intuition or their unsystematic clinical experience, or depending on the pathophysiologic rationale of the disease. And according to the pathophysiology, they just created a treatment and worked on that. So there were not any systematic review for research. So according to that, he proposed that researchers should collaborate internationally to systematically review all the best clinical trials, specialty by specialty. So researchers at that time, when they started this process, clinical practitioners began to notice that there is a huge gap between research and what is actually done on clinical practice. And as a result of that, they started to realize the importance of systematically reviewing research and having a strong evidence. But it was not until 1991 that the term evidence-based medicine or practice was first introduced, when Dr. Gordon Guyot and his team shifted the emphasis in clinical decision-making from intuition or unsystematic clinical experience and pathophysiologic rationale to scientific and clinically relevant research. So this is Dr. Archie Cochrane. And just for your information, the famous Cochrane Library was named after him. And about 80% of WHO guidelines are based on the systematic reviews found on Cochrane Library, and the other 20% comes from major clinical journals like The Lancet and New England Journal of Medicine. So in 1996, a Canadian-American doctor called David Loren Sackett just noticed that we cannot depend only on the research and directly implementing the result of any research we found on individual patient care. We have to combine both clinical experience and patient values to this. So the evidence-based medicine is not about only reviewing research and directly implementing the research into patient care. We have to combine our clinical experience is also very important. And of course, the patient is a very important part of this process. So all these three factors will combine together to make a decision about the care of individual patients. So starting from this slide, we are going to discuss the 6 main practical steps that we can use in our daily practice to implement evidence-based medicine in our practice. And before starting the discussion of these steps, we should notice that the evidence-based practice process begins and ends with the patient, and I'm going to discuss this in a moment. So the first step we can start with, if you want to implement evidence-based medicine, is to start with the patient. So as I said, this process will always start with the patient by identifying the patient problem. So the patient will come to you with a certain problem. This problem could be, for example, related to diagnosis. So the patient has a certain set of symptoms, and then as a physician, you are going to take some history and do a physical exam, and you are going to come up with some signs. And the problem is to combine those signs and symptoms into a diagnosis. Or the problem could be related to the treatment. So you already know the diagnosis, but you want to know the best treatment for the patient. It could be also related to a prognosis. Like the patient might ask you, what is the prognosis of my illness given the therapy that you provided to me? It could be a preventive question. How can I prevent this situation or this disease the best way? So the problem can be related to many aspects of patient care. So now that we identified the problem, and of course, any problem needs a solution. So the next logical step is to go and search in the evidence that we have so we can come up with the answer. But before coming up with the answer, of course, we have to have a question. So we can ask the right question to get the right answer. The question should be focused, precise, and to the point. Otherwise, if it's a wide question and poorly identified, like it's a broad one, we will not be able to get to the answer. And usually in a clinical setting, we don't have enough time to search broadly. So the more precise and focused our question is, the easiest that we can get to the answer. So an evidence-based practice question, usually, as we said, it revolves around many aspects. Those aspects, there are usually 6 aspects that we ask about. So the question might be related to diagnosis, therapy, prognosis, prevention, clinical evidence, or even education. And someone might ask me that I already know the diagnosis and therapy and prognosis of the disease since medical school. So why do I have to go and search in the evidence? This is because medicine is an ever-evolving field. And to be a good physician, we have to always use this skill, the skill of evidence-based medicine, so we can provide the best care for our patients. We should be updated. So a good question has 4 elements on it, and those elements are summarized by the mnemonic PQ. And the P stands for patient problem, the I stands for intervention, C stands for comparison, and O stands for outcome. So a good question has 4 elements. We should identify all 4 elements to say that question is a good one. So we will take some examples. So let's read the first question. The first question says, in a 42-year-old man with a history of heart attack, does aspirin reduce the risk of death? So we said that a good question contains 4 elements that are summarized by the mnemonic PICO. So let's identify the first P, which is the patient problem. So is patient problem clearly identified in this question? I think so, because it says a 42-year-old man with a history of heart attack. So we clearly understand the problem now. So the I stands for intervention. The intervention in this question is clearly aspirin, and the C stands for comparison. The comparison, it means that we compare the new intervention to the gold standard or to placebo. And the comparison in this question is not really clear, but it's implied. Like I can understand from the question that they are comparing aspirin to placebo or to nothing. So the comparison criteria is met. And the last thing is outcome. The outcome is clearly death in this question. So this is a good, precise, and focused question, and that we can ask, and it will narrow down and help us find the answer like as fast as possible. Let's take the second question as an example. It says, do antibiotics help children with cold? So as we did with the first question, let's identify the 4 elements. First of all, the patient problem, which is the first P in the mnemonic PICO. So the patient problem here is cold. Cold is a poorly identified word, like cold can refer to any upper respiratory tract infection. It could be acute pharyngitis, tonsillitis, bronchiolitis. So we don't know what cold he's referring to. And the other I stands for intervention. Intervention here is written as antibiotics. So there are many classes of antibiotics. Which class do you mean? So this is very broad. C is for comparison. Maybe comparison is met. It's implied, just like the first question. They are comparing antibiotics to nothing or placebo. And the outcome, it's mentioned in the word help. Help is also a very broad word, like what type of help? Is it like curing the illness or reducing the risk of something? So this is a very broad question that would waste your time if you ask a question like this. So always try to ask a question that meets all 4 criteria, similar to the first one. So now that in the first step, we identify the patient problem, we started with the patient, and in the second step, now we know how to ask a good, focused, and precise question. And the third step is obviously to search for evidence. So we have many sources of evidence-based information. It could be peer-reviewed articles, randomized controlled trials, scientific books, clinical guidelines, or selected websites. And my colleague, Dr. Marwa, will dive into depth to all these elements. She will discuss this in more details. So let's recap again. We started with the patient problem, identify the problem clearly, and then we know how to ask a good question. And then we identify the source of evidence that we want to search in. So the fourth step, and it's a very important one, is to appraise the evidence, to critically appraise the evidence. We will not believe any research paper that we come across. Why is that? Because even if you are searching in the best medical journals, in the best websites, there is still a chance of error. There is still a chance that this research, those results may be biased. For example, pharmaceutical companies who produce research, maybe they have conflicts of interest because they want to sell their products at the end to make profit of it. So same applies to medical devices, manufacturing companies. Maybe they want to sell their product and make a profit of it. So we always have to critically appraise a research paper using our knowledge and expertise. So there are 3 key questions that can help us critically appraise a research paper. The first one is the study valid? So we know that validity is divided into external and internal validity, and bias affects internal validity. Any type of bias affects internal validity. Internal validity, if affected, in turn, it is going to affect the external validity. And we know that if external validity is disrupted, this is going to cause or affect the generalizability of a study. So this study cannot be generalizable to the population and to the individual patient that I'm treating, who's a part of the population. So we have to have a good knowledge of statistics and good knowledge of all types of bias, so we can not just read the results and apply it to my patient, but also critically think about what I'm reading. So the second question is, what are the results? So are those results apply to my patient or not? Sometimes the results can be statistically significant, but they are not clinically significant. So there is a difference between the two. And if I have a good knowledge of statistics, I can understand all these. So will the results help my patient? So the results can be both statistically and clinically significant, but it won't help my patient at the end, because maybe the population in the study does not represent my patient. Maybe it's like a certain age group and my patient is out of this age group. So I always have to ask myself those questions. There are also some general rules that can help us critically appraise a paper. Always try to look for larger studies. They are preferred over smaller ones. So I will give you an example. If I'm doing a study about the incidence of HIV worldwide, and my sample size was from a small country where the incidence of HIV is high, maybe let's say 70%. So if I took my sample size solely from that small African country, I will erroneously conclude that the worldwide incidence of HIV is 70%, which is wrong. But if I take a large sample size from all continents worldwide, I might end up with a much smaller percentage, maybe like 2%, which is close to the reality. Also, a very important thing is to look to the methodology section. By looking to the methodology section, you can understand many information about the paper. You can look at the sample size we just talked about, and you also can understand what type of study it is. So the type of study is very important, because certain study types have stronger evidence than others. And this is what we are going to discuss in the next slide. So this is called the hierarchy of evidence, or the pyramid of evidence. In this pyramid, different types of methodology are arranged in evidence from the lower quality, which is on the bottom of the pyramid, up to the higher quality on the top of the pyramid. So if you look on the bottom of the pyramid, we have animal and laboratory studies, and we can understand why those type of studies are at the bottom, because obviously no humans involved. So how can I apply a study that does not contain any human subject to my individual patient? Of course, I cannot apply the results of those studies directly into my individual patients. Also, we have at the bottom case reports and case series. Because of their small sample size, they cannot be generalizable. So by going up to the top of the pyramid, we have meta-analysis and systematic reviews. So those type of studies, especially meta-analysis, combine many research studies, especially clinical trials, and give us the summary of all those studies combined. And because it's using a statistical method, so it's considered to be a very strong type of study and has a higher quality of evidence. On the top of the pyramid is clinical practice guidelines. So why clinical practice guidelines are, like, by some experts, they say that it should be at the top. Not all experts agree on that, but the majority agree on that clinical practice guidelines are the best, provide the best clinical evidence. This is because they combine expert opinion and evidence together. So as we said, that Dr. Lauren Sackett said that whenever the clinical evidence and expert opinion are combined together, this is going to be stronger than evidence alone. Because as we said, that evidence contain like there is a chance of error and bias. So let's recap again. We identify the patient problem in the first step. On the second step, we know how to ask a good question, and then we identify the source of evidence that we want to use. And on the third step, on the first step, we know how to critically appraise a paper, which is a very important skill. Now at that point, hopefully, we came with the answer. And now it's time to act on the evidence. It's time to implement the answer that I found to my patient care. At this point, I'm going to return to the patient again. So I started off with the patient and went through all those steps. Now I'm returning to my patient. So it's important to understand that this is a shared decision-making process. Of course, I'm not going to implement what I have learned from all evidence and clinical experience without the patient consent. And of course, this consent should be informed consent. It's a shared decision-making process. So I'm going to discuss with my patient everything that I have found. I'm going to discuss the advantages, the disadvantages, and the alternatives so the patient can make an informed decision. So after that, the last step, so after you find some time and you're not busy, you can do a self-evaluation. Self-evaluation is important. So in this step, you just self-reflect on the process you did. So you just sit and think about, are you satisfied with the process? Is your patient satisfied with this? What type of research paper that you read, and what type of evidence. So this process of self-reflection will help you better refine your evidence-based medicine skills, and you will be better the next time. So although evidence-based medicine is a great skill to learn and it will help us be like great physicians, but unfortunately there are some barriers to implementing this. The first barrier is lack of human resources. So this includes lack of teamwork, lack of physicians, conflicts between healthcare workers, so affecting the teamwork, and this is obviously a great barrier. The second barrier is lack of internet access at work. And of course, many clinical journals and websites are online, and having lack of internet access is a big problem. The third barrier is lack of access to a rich library with journals, especially if we are practicing in a non-academic institution. Also, heavy workload and limited time, those points are related to each other. If I have like limited time, I cannot base all my clinical decision using like evidence-based medicine. I will usually just work based on my intuition or clinical experience because I have no time to go and search like every answer for every question. Of course, lack of evidence-based medicine skills is going to be a barrier because you might have noticed that it's a skill. We have to ask the right question and we have to critically appraise a paper, and not all practitioners are familiar with that. So the seventh barrier is inadequate research evaluation skills. Of course, it requires statistical knowledge, and not all doctors remember the statistical knowledge that they have learned in medical school. Also, publication bias and conflicts of interest. I just gave you an example of the pharmaceutical companies and the medical devices manufacturing companies. They might like have some conflicts of interest. They want to sell their products at the end and make a profit of it. Also, there is a 10th barrier that I have not written here, and it's that like evidence is not black and white. Usually in our clinical decision, we want an answer that is black or white, like, should I give this treatment or not? Should I proceed with surgery or not? So evidence usually does not provide this black and white answer. It will tell you like this medicine is going to be 50% effective in this age group, and there is a percentage like 20%, it will cause side effects. So it needs some time to use your clinical experience in order to get to the answer of yes or no, because evidence will not provide this answer to you usually. So thank you so much. This concludes my part. Dr. Marwa, if you are ready, you can continue with the presentation. Thank you so much.
Amazing. Thank you so much, Dr. Amal, for this informative lecture. It was really nice. So I will try to share my screen. Hello, everyone. My name is Marwa Morgo. All right. My part will be lighter and shorter than Dr. Amal. I hope everyone will enjoy it. I believe our topic, it's really important for people that are trying to apply and practice medicine at any place, actually, United States or at any place, because everyone expects you to be familiar actually with all type of researchers. And just if Dr. Amal don't mind about the PICO actually, can you, sorry, everyone can see my screen and can hear me well or no?
Yes, we can hear you clearly.
Amazing. Thank you. You can see my screen, yeah?
Yes.
Thank you. So about the PICO, actually, I just want to add, being part of residency program here, ECFMG certified and credentialed program, actually, I have the luxury of practicing that on weekly basis. As a resident or as a general practitioner, I believe that you should be familiarize yourself with at least the main tools of appraise any topic or any paper. There is a lot of tools actually we use it for critically appraisal. Dr. Amal highlight for the PICO. This is the first and the most easy, like the easiest tool we use. There is something called ROP1 and ROP2 and other different tools. If we had the opportunity, hopefully in the next week, I would love actually to share this topic. Like we'll bring some papers and practice critical appraisal if we had chance, hopefully in the future. But I highly recommend to guys get familiarized with these two, because you will need it in your practice. Right. Now talking about it, what's the main sources we will use at any basically like, for instance, I decided to do meta-analysis or systemic review or case report. Whatever like you decide to do as a resident or as a specialist or whatever, where like you are practicing, you needed always to be up to date by read about a certain topic, or even try to publish something, right? So there is certain website and certain resources. Some people they recommend, and some people they trust more than the others. Of course, I believe like everyone here know about the about PubMed. Most likely you use it at some point in your practice. The advantage of PubMed, there is quite disadvantage. I will mention a few of them, but at the moment, like advantage wise, you know that it's freely available, so it's free online resources, online resource. Most of like researchers and everyone can basically has access to it. And PubMed, there's almost like a 300 million citation, right? There is connect you directly to journals and take you to the main source where the primary, the paper published actually. So it can connect you to a lot of point in the same source and the same page. And that's really nice about PubMed. The other thing about it, PubMed, we know that it's produced by the National Library of Medicine, which is part of National Institution of the Health. So we consider it to some extent, it's trusted source of biomedical information. And PubMed, it's up to date. We always see the new papers, people and researchers actually they try to publish and to make their papers reach to the PubMed, because it's really trustful and it's really worthy place to have your paper on it. Somehow the engine and the way you will search in it, it's quite easy and compared with other places, well organized. If we had time, we'll talk about it, the mesh, which is the medical subject heading, which is tool actually in PubMed made research quite easier. If you're looking for certain article or certain idea or certain topic and you try to search, because we mentioned there is millions actually of citations. There's almost 5,000 up to 6,000 biomedical journals in PubMed. So sometimes it's a little bit confusing to search through it. So mesh criteria made it quite easier for us. If you have certain ideas, certain queries about it, certain disease, about certain treatment, you can just type in the PubMed and it will pop up in front of you. So it's really easy. And as I mentioned earlier, link out, so it will link many available online and journals and a lot of citation, all of them in the same place. So it make your life easier. Right. Sorry. All right. This is the first one we will talk about it. The others we will go basically for the evidence-based medicine for primary care and internal medicine, basically ACP Journal Club. One of the things we know about it, it's peer review. When you see the word of peer review for any journal club, that means there is high quality actually of a trust in that source. It's more objective. There is less bias on it, less subjective element to affected I mean this source to use it in your research or in your paper or to build your information from it. So be reviewed, of course, by expertise in certain field. Also, it's up to date, easy to understand, and evidence-based, and with a lot of recommendation on it. So you can have like a new information, you can build your information and build decision regard certain topic, regard care of one of the patient according to the advice and recommendation in this journal. And also it's linked to the Duke University, and that add more accreditation to the source, and it's make it more, all of us know that this university, it's one of the prestigious university in the world, so that add more actually accreditation and more made it more trustworthy. Most of the topics in it is freely available online, so it's easy to access. It's clear, you can search on it by the topic, by the author name, publication date, all of that organized in a way it made it easier to reach to the info you needed to educate yourself or to answer certain question you had in mind. Right. Cochrane, and I believe my colleague Dr. Amal mentioned that quite well, mentioned that most of the research, like 80%, it's rely actually in Cochrane library. I mean, as a main source, it's include most of the systemic review. We talk about it now in our practice, and we will have critical appraisal or we have discussion about it, certain papers, we always go for Cochrane library as main source. There is a lot of methodology in it. It's comprehensive coverage, of course, with a wide range of the healthcare topic. It's really beautiful and nice source to use it to learn about the treatment, learn about the disease, up to date, of course, easy to use and freely available, of course. Right. Cochrane review include summaries at the end. Also, they make like nice addition that they try to make some sort of summary for certain topics. Just if someone is not expert about that topic, to make it like in a plain language, to make it easier. So the aim in this library definitely try to educate as much as they could from people. As a comparison, if we mention, okay, we know that we had PubMed, and now we talk about Cochrane library and which one to which and which one is better and how you make differentiation. I always imagine PubMed versus Cochrane library, that PubMed, it's like unfiltered like source of primary literature kind of review. It include different kind of publication, like all the academic journal without filter, like primary sources, compress all of it together. But Cochrane, it's a pre-filtered. It's only carefully include critically well appraised, with high level of trust and less level of bias on it from publication, of course. So somehow Cochrane is still actually I'm in favor of Cochrane on compare with PubMed. Because as I mentioned clearly, like the way they mention it, I mean, they look for a lot of elements before include any paper there, like carefully appraised and selected in certain places and should be synthesized publication, but without clear filters and all the publication being in, that's somehow PubMed. So Cochrane is still more organized, still the trust in it to use any paper published there or any info there, it's higher than basically PubMed, even though both of them good resource to use it in our practice. Right. And the rational clinical examination as evidence-based research source also, it's really basically good place to learn from, because you will see certain articles, as Dr. Amal mentioned, that clinical practice and clinical experience play major role in evidence base, because we basically build and rely on it to write our guidelines, what believe like certain approach to treat and this and that. Right. So here you will see certain articles from expert people in certain topic. They will write their experience. They will write what they think it's right. Sometimes they will use simple language just to make it easier and make sure that it will be accessible to everyone. Right. And from there, you can actually use their advices in our daily practice, and try to reflect that in our physical examination, our treatment plans, and consider it as tips. We use it in daily basis. About this source, it's really up to date. I really like the idea that they will give you the conclusion, the summary of their expertise, like in certain topic, and you will just absorb it and learn it, and you will have this expert, like you have those knowledge with you, and you can apply them in daily basis on your basic in your patient. And that's the advantage of this source, and compare with the previous two sources I basically mentioned them. Right. All right. The turning research into the practice source, TRIB, also help clinicians to identify and appraise and implement the best available research evidence into the practice. Almost the same with systemic of course approach, by use the clinician at all level of expertise. Right. It's like evidence-based framework. It's a start with the step by step. Then after that, they will start at the appraising like certain research, and they give you like what's the third like certain opinion. Then after that, they try to end up with a step-by-step guideline. It's really flexible and adaptable, as we mentioned, evidence-based, up to date, and free and easily easy accessible. Yeah. Some specific example here, we mentioned that a clinical who is treating patient with a complex medical condition, we can use that actually to appraise what's the best available research evidence on effectiveness of different treatments. So by this source, you can see like what the clinician believe that the best treatment, and from there you can use it to improve actually your patient care. Also the nurses, how they interact, to how they intervene as an educational level, pharmacists. So all the medical field with different specialty, they can use that. And the best part about it, you can immediately, after, of course, proper appraisal, you can apply it on your daily practice. I'm not sure, sorry, if you can hear this voice. This is like a video 3 minutes for MESH, the one I mentioned in the PubMed, explaining actually, I'm not sure you can hear, guys, the source, or you can hear the voice or not.
Yes, we can.
Yes, we can.
If you can just elevate the voice a little bit.
Sure, I'll try my best. I think this is the loudest thing I had. So 3 minutes just to give you idea how to use it. Before this lecture, I did not know about this character in PubMed, and I think it's really nice to know it. It will help you a lot with your work. Okay, so let's try to open it again. Okay. Yeah.
This video demonstrates how to use the MESH, or Medical Subject Headings database, to create a targeted PubMed search. From the PubMed homepage, in the More Resources section, I'll click the link to the MESH database. MESH is the controlled vocabulary used for indexing PubMed citations. Let's say I want to find articles about problems associated with giving flu vaccines to individuals with egg allergies. I'll first search for flu vaccine, which returns the MESH term influenza vaccines. The page displays a definition and additional information about the term. In the MESH database, terms are arranged hierarchically by subject categories, with more specific terms arranged beneath broader terms. You'll notice that influenza vaccines is listed under viral vaccines, which is under vaccines. I'll click vaccines to display the variety of terms available under this concept. Let me take a two-sentence aside here to mention how mesh terms help your searches. During the indexing process, the most specific mesh terms are applied to a journal article. Then during your PubMed search, mesh terms recognized in the query are automatically mapped to the most specific terms, and those are included in your search. Okay, I'll click back to influenza vaccines and continue with my search. These subheadings may be used to narrow the search. Since I'm interested in the negative effects of the flu vaccine, I'll click the subheading Adverse Effects, and then click the button Add to Search Builder. I want to further limit to articles on egg allergies, so I'll search mesh as I did with flu vaccines to find the appropriate mesh term. I'll enter egg allergy in the search box at the top of the page. The database displays the mesh term egg hypersensitivity, which I'll add to my PubMed search by clicking the Add to Search Builder button. I'm now ready to search PubMed, so I'll click Search PubMed. This search retrieves a relatively small number of targeted citations. You'll notice that all of these citations are tagged with the text PubMed indexed for Medline. This indicates that the citation has been indexed with mesh terms, but please keep in mind that not all PubMed citations are slated to be mesh indexed, and it may take several weeks for a new citation to be indexed. So using mesh terms will limit your results to a subset of PubMed citations. To see all the mesh terms used to index an article, click on an article title, and then click on the mesh terms label. Each mesh term includes a menu that can be used to search the term in PubMed or mesh. Back on the mesh homepage, you can read more about using mesh by following the help link and send questions by using the link.
Yeah, so just to give clue, like give certain idea about it, the mesh, you will see the benefit of mesh mainly when you try to search, like you have certain idea and you're trying to do research, for instance, and you're trying to look for two factors to try to connect them together. When you try to search in PubMed, you will see a lot of papers. Some, like, you will spend time and you will end up like 100 paper. Sometimes this paper is not clearly linked to your own idea. So mesh will save actually your life and make it quite easier for you. Before we go to question, guys, just to like recap the message we try to deliver today, please familiarize yourself with using evidence-based practice with everything, even when you have like a proper discussion with another physician. Familiarize yourself how to appraise any paper and what kind of research apply to our practice and our population. Sometimes the paper, even though it's basically when you like run Pico or run like Rob-Tool or whatever you are using, this paper is still not applied to your society or to your own population. There is a lot of factor, a lot of element. So we needed to actually to learn that. And is it good enough to change our practice? When you read something, is it good enough to change your practice to use it in daily basis or not? I believe as a physician, as people, they're trying to learn and improve their, like as a fellow, actually, we should know these tools, and hopefully we will have like another opportunity. I would love to participate and explain it, of course, with help of others even further. Thank you so much. If you have any question, any feedback, if you hate it, if you like it, please let us know. Thank you so much, everyone. Thank you, Dr. Nader.
Thank you so much, Dr. Marwa. This was a great, amazing, and beneficial presentation. Do you have any questions or comments?
Guys, I'm kind of person, I really like the feedback. So please, anything. You don't need to be nice. It's fine. Like, this is how we improve. So please let us know if I did well, if I did not do well, what we should improve next time. So please, yeah, let us know. So that's how we learn, all of us. And thank you so much. Thank you, Dr. Nader, for the opportunity. Thank you, Dr. Amal.
You're welcome. Thank you so much.
Thank you, Dr. Marwa. This is excellent presentation, and it's very useful, concise, and hopefully people will benefit from it. Thank you.
Thank you so much, Dr. Nader, for the great opportunities. I think Dr. Abdelwahab is back. So let me know if you are ready, Dr. Abdelwahab.
Yeah, I'm ready, Dr. Amal.
Okay, sure. I will start by sharing my slides.
Okay. Okay. Hello, everyone. This is me, Dr. Abdelwahab Ahmed, and me and Dr. Ammar Mahmoud are going to present a topic about stroke and cerebrovascular diseases. Okay, go for the next slide. In this topic, our objectives will be to, after completing it, we must be able to describe the impact of cerebrovascular diseases on older adults, the treatment of acute ischemic stroke, and how to recognize transient ischemic attack, TIA. And we will also learn about the prevention of ischemic stroke and the prevention and treatment of hemorrhagic stroke. So, go for the next slide, please. So the topics that we are going to cover here today is firstly about the impact of cerebrovascular diseases, and then we will discuss about the two types of stroke, which are ischemic stroke and hemorrhagic stroke. I'm going to talk about the ischemic stroke, and Dr. Ammar will talk about the hemorrhagic stroke. So generally speaking, ischemic stroke is caused by either it's either to be a thrombotic or embolic, or it's can be hypoxic. So the thrombotic stroke is actually due to atherosclerosis within one of the arteries of the circular fields, like the anterior cerebral artery or the middle cerebral artery. So you get an occlusion in the circular fields. And the embolic one is from a source that is outside of the head. So it's would be from the heart, like in patients with atrial fibrillation, in which there is a coagulation of blood in the left atrial appendage. So it will shoot into the circular fields and cause the stroke. It can also be from the carotid arteries when there is an atherosclerosis within the carotid arteries. So it's also will form an emboli that can cause a stroke. So firstly, when the patient is presented to the hospital, they usually present with weakness, and sometimes there is mouth defecation and other symptoms. So we start by taking a history, careful history about the weakness and other neurological history. Then we must do an examination of the patients, and particularly the neurological examination. We must also assess the cardiovascular system for any type of valvular disease, or we must also check for atrial fibrillation through the pulse if it's irregular. We must also check the carotid arteries for stenosis, like by palpation and by auscultation. And after that, we must order investigations. Investigations number one for identifying the type of stroke, and that will be by conducting or by ordering an non-contrast CT scan of the heads. So that's from that we can know whether it's an ischemic stroke or a hemorrhagic stroke, and then we can start the treatment. Then after that, we will order investigations for the causes and investigations for the risk factors for the disease to manage it in the next steps. So next slide, please. That was generally speaking about the ischemic stroke. So impact of cerebrovascular disease. The incidence of stroke increases with advancing age, and it's approximately doubles each decade. It is a leading cause of disability and death among older adults. So stroke 6 months after a stroke, in those 65 or more, 26% are dependent in activities of daily livings, and 46% have measurable cognitive deficits. The fatality rate within 1 month of an acute stroke is 20% to 30% across all age groups. And the common medical causes of death associated with stroke are myocardial infarction, arrhythmias, heart failure, aspiration pneumonia, and pulmonary embolism. And this because when the patient has weakness, so he cannot move, so that will form a clot like DVT, and that will cause pulmonary embolism. He may also have mouth deviation and problems with the swallowing, so he can get aspiration pneumonia. So yeah, these are the medical causes that can cause death among patients with stroke. Next slide. So, ischemic stroke is caused by occlusion of the cerebral blood vessels. It accounts for approximately 80% to 85% of strokes. So it's more common than the hemorrhagic stroke. So knowing the cause helps guide treatment and prognosis. About 27% are due to cardiac emboli, 19% are due to large vessel disease, 17% are due to small vessel disease, and 35% cannot be classified. Next slide, please. So the small vessel disease, it causes occlusion of small penetrating vessels due to lipohyalinosis, which is lipid deposition and hyalinization, or local arteriosclerosis. So it causes ischemic stroke that are typically less than 1 centimeter, and it's termed lacunar strokes, lacunar infarcts. And risk factors for this infarcts are hypertension, diabetes mellitus, smoking. So lacunar strokes can occur concurrently with other mechanisms of ischemic stroke. Okay. The second cause of ischemic stroke here is large vessel disease, and it's commonly called by atherosclerosis. So large vessel diseases, these are the vessels that supply the cortical areas. So so they are like the middle cerebral artery, anterior cerebral artery, and their and atherosclerosis enzyme and ischemic stroke enzyme will cause cortical symptoms along with the weakness. So the patient can have loss of consciousness, will have aphasia, agnosia, cortical symptoms. But in the previous small vessel diseases that cause lacunar infarctions, those will not have cortical symptoms because they are in the subcortex. So patients will have like pure motor stroke or pure motor sensory stroke. So they will have no sensory, they will have no cortical symptoms. Here in the large vessel diseases, it causes atherosclerosis causes progressive occlusion of the cerebral vessels in the anterior or posterior circulation. Can be identified by non-invasive imaging of the carotid arteries, Doppler ultrasonography, CT angiography, MR angiography, or conventional angiography. Risk factors for this atherosclerosis are hypertension, hyperlipidemia, diabetes, and smoking. So regarding the ischemic stroke that come from emboli, particularly from the heart, it is called the cardioembolic stroke. Cardioembolism is an important, potentially preventable cause of ischemic stroke. And when it's come from the heart, it's likely atrial fibrillation. It's the most common cause that causes clots in the heart that causes stroke. So it's associated with a 4 to 5-fold increased risk because of thrombus formation in the left atrial appendage and cardioembolism to cerebral vessels. The cardioembolic stroke due to atrial fibrillation accounts for 25 to 30% of all ischemic strokes. So it has a large contribution to the strokes in general. So as we said, cardiovascular examination is an important part of the assessment of a patient who presents with stroke symptoms. Cardioembolic stroke often occurs without preceding TIA. So we also have cryptogenic stroke. And when we say cryptogenic stroke, we mean it's the ischemic stroke that does not have a clearly identifiable cause. So it's not from the heart, it's not from due to atherosclerosis within the circle of Wills. So we don't know where from where this ischemic stroke came. So we call it a cryptogenic stroke. So use brain and vascular imaging to assess the size of the vessel involved. Then we should here, when we do not know the cause, we should consider atypical causes of stroke, such as vasculitis, coagulopathy, mitochondrial disorders. So we also need to put these patients on prolonged cardiac monitoring because it's needed to capture intermittent atrial fibrillation as a potential cause of cryptogenic stroke. So now, what if a patient presented with stroke symptoms after, what should be our immediate treatment of acute ischemic stroke? Typically, we must order HCT imaging to determine whether the patient is suffering from an ischemic stroke or hemorrhagic stroke, as we said before. And after we determine that and starting the appropriate treatment, we should also assess the severity and pattern of neurologic deficits, such as by using the NIH stroke scale, which is a scale that we use the score that we get from it to know whether this patient has a poor prognosis or a good prognosis. So it assesses the severity and of the neurologic deficits, or the severity of the stroke. Then we should identify non-stroke causes of acute neurologic dysfunction, such as migraine, seizures, and drug intoxication. So after confirming, so we confirm this is a stroke with the workup and by exclusion of the other possible neurologic deficits that can present with stroke-like symptoms. The NIH stroke scale, it is a scale that we use to assess the severity, as I said. So if the score was less than 5 points, it's against very good prognosis. If it was more than 20, it's against a very poor prognosis and a higher risk of major complications. So here's the symptoms and the criteria that is used to calculate the score, so we can know whether this patient have a good prognosis or a bad prognosis. Next, please. So what would be the acute care of the older stroke patients? So firstly, we should optimize hydration status. So gradually to prevent cerebral edema. We should also control blood pressure while avoiding hypotension. So this is a technique that is called permissive hypertension. We should not lower it too rapidly. So also we must take the measures to prevent deep vein thrombosis, and we must detect and treat coronary ischemia, whether it's present or if there is heart failure, cardiac arrhythmias. And then we should start long-term antiplatelet therapy or anticoagulation. In addition to that, we must also normalize body temperature and blood glucose. So if we, in the management of ischemic stroke, we use the recombinant tissue plasminogen activator, the RTPA. One of them is alteplase. And when we should consider alteplase in the management of ischemic stroke, that would be if the patient presents within 3 hours of neurologic deficits, and the CT confirms absence of intracranial hemorrhage. So then we can consider using alteplase. The AHA recommendation is prolongation of the window to 3 to 4.5 hours for patients less than 80 years old who have NIH score less than 25 and no prior history of stroke or diabetes. So here If they present even 4.5 hours after the symptoms, we can use the alteplase when these criteria are met. So its use requires careful assessment by a clinician experienced in treatment of stroke, and it carries a 6% risk of intracerebral hemorrhage, usually among patients with severe strokes. So we must be cautious in the use of the alteplase. So alteplase has contraindications to its use. Because if you used it with one of these conditions, the patient is at high risk of intracerebral hemorrhage. So that's why alteplase should be used by an experienced clinician in treatment of stroke. So these contraindications include major surgery within the previous 2 weeks, previous intracranial hemorrhage, hypertension, like when the systolic blood pressure is more than 185, or the systolic blood pressure more than 110 millimeter mercury, symptoms of suprachoroidal hemorrhage, recent uncontrolled bleeding, if the patient has coagulopathy, or if he has thrombocytopenia, or when the patient's INR is more than 1.7, here alteplase is contraindicated. So there is a 4 recent randomized clinical trials about the use of alteplase in addition to endovascular thrombectomy. So endovascular thrombectomy in patients with proximal large vessel occlusions of the anterior cerebral circulation provided significant benefit when treatment began within 6 hours of stroke onset. So most patients receive alteplase before endovascular thrombectomy, and the use of alteplase before endovascular thrombectomy showed benefits, and they were at 24 hours, 50% reduction in NIHH score, and at 90 days, there were significant improvements in the function of the body of the patient who had a stroke. So the use of alteplase before endovascular thrombectomy is highly supported by researchers. So now let's talk about the transient ischemic attack. So it's defined as a brief episode of neurologic dysfunction caused by focal ischemia to the brain or spinal cord that does not result in acute infarction. So traditionally thought to be last up to 24 hours. So we say that the patient had stroke symptoms and it's resolved, didn't continue more than 24 hours. So we say, yeah, this patient had a TIA. But newer imaging makes it clear. TIA typically lasts less than 1 to 2 hours. So it's not, it's resolved in less than 1 to 2 hours, but the symptoms may continue up to 24 hours. But on imaging, it's cleared in less than 1 to 2 hours. So longer episodes are commonly associated with acute infarction. So if it's extended for long periods, it's likely associated with an acute infarction. So this is the new evidence and the definition of TIA. Major risk factors, it's a major risk factor for a subsequent stroke. So patients who had previous TIA are at higher risk than the general population to get a stroke in the future. So after a patient being diagnosed with TIA, how we should manage him? TIA symptoms should be evaluated emergently. We should take it serious. We should do brain imaging, ideally with MRI. Is important and that is important to determine whether there has been an acute stroke, and if one is found, its location and type. So we should investigate it as a stroke. So non-invasive imaging of the carotid arteries, EKG, and echocardiography are important to determine the most likely causes of ischemia. So we should identify it by imaging, and then we should search for the cause, whether it's the heart or whether it's the carotid arteries, from where this imply that shooted and caused this TIA. we should identify the source. Then we should initiate treatment for secondary stroke prevention based on the results of the evaluation, because they are at increased risk for stroke, as we said. So now let's talk about how to prevent ischemic stroke. Preventing it in patients who had a stroke before as secondary prevention, or preventing it from occurrence in patients who are at high risk for developing stroke, like patients with hypertension, hyperlipidemia, diabetes, smoking. So they should start the preventive strategies for stroke. So blood pressure therapy should be started to maintain systolic blood pressure less than 140 and diastolic less than 90 for secondary stroke prevention. And for primary prevention in those with other risk factors such as diabetes, statin therapy for primary prevention in patients is estimated to have a high 10-year risk of cardiovascular events based on the AHA guidelines. So high statin therapy for patients who have had a TIA or stroke believed to be of atherosclerotic origin, regardless of the LDL-C levels. So they should start the high intensity statin therapy. Next, please. So several studies have confirmed a 2 to 4-fold increased risk of stroke in individuals with diabetes mellitus. So diabetes alone carries a significant risk for stroke. So aggressive treatment of hypertension and hyperlipidemia in diabetic patients is crucial. So because they will be an added risk factor to diabetes to develop stroke. So we should treat it and treat other risk factors. Some research suggests that tight control of blood glucose levels in healthier adults with diabetes might reduce the risk of stroke, although the evidence for reduction of other vascular complications, retinopathy, nephropathy is more compelling. So by evidence, careful management of diabetes would suggest the risk of stroke, while in the same time it might not reduce the risk of retinopathy and nephropathy. But for stroke, yeah, it's work to managing it. It's work to prevent the stroke. Support cessation of smoking, which increases the risk of stroke as much as 3 folds. Yeah, so stop smoking can prevent a stroke. Next, please. Other preventive strategy of ischemic stroke is the long-term oral anticoagulation therapy use, and it is recommended for patients with valvular and non-valvular atrial fibrillation at high risk of stroke and low risk of hemorrhagic complications. For valvular atrial fibrillation, warfarin dosed to a target of INR of 2 to 3. For non-valvular atrial fibrillation, first-line options are warfarin with INR 2 to 3, or here we have other options other than warfarin, like apixaban, edoxaban, or rivaroxaban, with dabigatran as an alternative. So we can also consider aspirin for patients with non-valvular atrial fibrillation and low risk of stroke. So if the patients with atrial fibrillation, if he has valvular atrial fibrillation, the only treatment is warfarin. But if it was a non-valvular atrial fibrillation, we can use other options than warfarin. So if possible, initiate oral anticoagulation within 14 days of the TIA or stroke in those with atrial fibrillation. So within 14 days, we should start the anticoagulation therapy. Next, please. So following non-cardio embolic ischemic stroke, aspirin is the mainstay of antiplatelet therapy for secondary prevention. If it's if the source of the emboli was not the heart, aspirin is the mainstay. But if it was the heart, aspirin is the mainstay. So the minimal necessary dosage has not been determined. Other antiplatelet medications have not shown consistent superiority to aspirin. So sustained release dipyridamole combined with aspirin clopidogrel can also be used. We can combine clopidogrel with aspirin in the treatment for the non-cardioembolic ischemic stroke. We can use these treatments in 2 large trials. No benefit was found for the use of warfarin over aspirin for secondary prevention in the setting of large vessel disease, including intracranial atherosclerotic disease. So warfarin is basically used when the source of the emboli, as we said, from the heart. But if it was the carotid arteries, the emboli come from there, or if it was thrombotic stroke that was originally initiated in the cerebral fields, aspirin and clopidogrel has a superiority than warfarin. Warfarin use showed no more benefits than aspirin. Next slide. Next slide, please. Next slide, please, Amal.
So I'm moving. Maybe your screen is
So, Amal,
frozen.
can you hear me?
Yes, I can hear you clearly. I think your screen is frozen. That's why it's not moving on your screen.
Okay, so yeah, now it's moved. It's the hemorrhagic stroke. Can you go for the previous slides, please? Okay. Oh, okay. So, no. The slide which is about managing. No.
Should I go back or?
Yes, the slide which is after the prevention slides. Go for the previous slides. No, the previous one. Not you are moving forward.
Backward.
Please move backward.
Okay.
Yes, here.
For the sake of time, maybe we can skip the cases.
Okay, so no, this is slide, not this slide. The slide which is about.
Can you give me the number of the slide?
Okay, it's a slide which is after the prevention of ischemic stroke. There were 4
Dr.
slides
Amal,
about
it's slide number 22.
So do you mean this hemorrhagic stroke?
If you can, please go to slide 22, number 22.
Now
please.
I'm on slide 22.
Yes,
Okay,
that's
fine.
where you stop, Dr. Amal.
Okay.
Okay, thank you, Dr. Ammar. Thank you, Dr. Ammar. Okay, the slide which is after this one. One slide more.
Yeah, but I have some problem with my keyboard. Just a minute. Sorry for that.
No problem.
Okay.
It's not hemorrhagic stroke. The slides which is for it.
This is
Yes.
the slide. Okay. Prevention.
After the prevention slides. Yes, here. Treating cryptogenic stroke.
Okay.
Okay. So sorry for the interruption, doctors. So treating cryptogenic stroke, evaluate and treat modifiable risk factors and initiate antiplatelet therapy. So if a cardioembolic cause is suspected, then prolonged cardiac rhythm monitoring for atrial fibrillation is reasonable, and oral anticoagulant therapy should be initiated if intermittent atrial fibrillation is found. In the setting of patent femoral oval and venous source of embolism, oral anticoagulation is recommended. So if anticoagulation is contraindicated in such a patient, then an inferior vena cava filter or transcatheter BFO closure can be considered. So these are the two most common causes of cryptogenic stroke. It's either to be due to atrial fibrillation, which was not detected at investigation, or it was due to a patent foramen ovale. So we should treat the condition based on suspicion. Okay. For the next slide, please. Okay, go for the next slide, please.
This is the next slide, Dr. Abdelwahab.
It's still presenting for me as the previous slide. Okay, yeah, managing ischemic stroke. So all patients with cerebral atherosclerotic disease target modifiable risk factors, prescribe daily antiplatelet agents and statin. So patients with more 70% or more symptomatic carotid stenosis, we should do for them carotid endarterectomy. And patients with recent TIA or ischemic stroke and ipsilateral moderate 50 to 69% carotid stenosis, we can consider carotid endarterectomy for them. And for patients who are asymptomatic and have more than 70% stenosis of the internal carotid artery, we can consider carotid endarterectomy, CEA, or endovascular treatment with carotid artery angioplasty. Sorry, Dr. Amal, the slides are moving. Okay, so but only if the preoperative risk of stroke, myocardial infarction, and death is very low. So here we can consider the treatment of stenosis. Go for the next slide. Okay, so here my part in the presentation is ended. Dr. Ammar, Mahmoud, you can continue.
Thank you, Dr. Abdelwahab, and thank you, Dr. Amal. So I will be presenting the hemorrhagic stroke, which accounts for 15% to 20% of all strokes. We have four main subtypes: intracerebral hemorrhage, subarachnoid hemorrhage, and we have the subdural hematoma and epidural hematomas. Presents with abrupt onset of focal neurological symptoms. So often associated with severe headache, vomiting, very high blood pressure, and coma or decreased level of consciousness. It carries a higher risk of mortality than ischemic stroke and is best treated in comprehensive stroke centers. Emergent brain imaging, such as HIT CTs, is needed to determine whether a stroke is hemorrhagic or ischemic. So for acute care of intracerebral hemorrhage, patients with systolic blood pressure of 150 to 220 millimeter mercury, and a lower systolic blood pressure to 140. So we'd work on lowering the systolic blood pressure to under 140. Patients on warfarin, intravenous vitamin K, and therapy to replace vitamin K dependent clotting factors to normalize the INR. Patients with severe coagulation factor deficiency or severe thrombocytopenia, we have factor replacement therapy or platelet as needed. All anticoagulant and antiplatelet therapies should be stopped in the acute period. Management following the intracerebral hemorrhage, we control blood pressure with a goal of under 130 systolic and under 80 diastolic. In patients at high risk of future ischemic cerebrovascular events, such as those with mechanical heart valves and prior ischemic stroke, anticoagulation may need to be restarted within 2 weeks of the hemorrhage. In all others, withhold oral anticoagulation for at least 4 weeks to prevent recurrent hemorrhage. For subarachnoid hemorrhage, caused by a rupture of intracranial aneurysms, 80 to 85% of cases, or another abnormality of cerebral vessels, such as arteriovenous malformations. The risk factors for rupture is the size of the aneurysm and the older age, female gender, posterior circulation location, enlargement of the aneurysm over time prior to subarachnoid hemorrhage. Patients with an aneurysm at high risk of rupture should be referred to a neurosurgeon. Acute management of subarachnoid hemorrhage is similar to that of intracerebral hemorrhage, but includes surgical intervention and focuses on detection and treatment of atrial vasospasm, which is a common complication. With subdural hematoma, which is defined as a collection of blood between the dura and the arachnoid, usually due to head traumas, although the trauma may be mild, particularly in older adults. Bilateral in approximately 15% of cases. Some older adults suffer from chronic subdural hematomas that may be symptomatic. So with the incidence of chronic subdural hematoma, it increases with age. As you can see here on the graph, with the age group over 70 to 79, no history of head injuries in 50% of cases. And we have other risk factors, which is clotting disorders, shunting procedures, and seizures, which all contribute directly to increase the incidence. With the symptoms of chronic subdural hematoma, they usually present with headache, slight to moderate cognitive impairment, focal neurological signs like hemiparesis and hemisensory loss. Some individuals develop seizures with or after a subdural hematoma, during having the hematoma or after. The treatment of chronic subdural hematoma. If it's symptomatic and the patient is undergoing like a worsening of symptoms, removal of the clot may be attempted. With the asymptomatic and with the patient condition improvement, clinical monitoring is appropriate because the hematoma may resolve without surgery. So choosing wisely, recommendation based on the American Board of Internal Medicine Foundations Choosing Wisely campaign. So the recommendation is to not perform carotid endarterectomy for asymptomatic carotid stenosis unless the complication rate is lower than 3%. So as a summary, cerebrovascular disease is the leading cause of disability and death among older people. Acute stroke treatments can effectively improve outcomes in patients, especially when provided soon. Especially when the care is provided soon after stroke symptoms begin, and in a multidisciplinary stroke center. Primary and secondary stroke prevention can significantly decrease the burden of cerebrovascular disease in older populations. And now we have few cases that we would like the doctor to participate.
For the sake of time, Dr. Ammar, we can skip the cases. So, but thank you so much. If you want to add anything else, this is great. Yeah.
Yes, I wanted to say public speaking and presentation is not my strongest suit, and I'm very inspired by my colleagues who presented before me, and thank you very much for the opportunity, and I thank everybody in the group. And if there's any questions, yes.
Yeah, you did great. Excellent. So this is an opportunity for you guys, all of you to participate and learn and practice. And so both of you did great, excellent presentation. It's an important topic. It's a big topic. So we want to see, share all this information so that people can understand and refresh their knowledge about stroke, and if we can help our patients in the future. So thank you so much. This is a great presentation. So for the sake of time, we can skip the cases. Any questions for any of the presenters? If not, we can move to the next topic.
So thank you so much, Dr. Ammar and Dr. Abdelwahab, for the great and very informative presentation. Our next presentation is going to be about multi-element care transition models, and it will be presented by Dr. Fatima.
Hello, everyone. I hope that you're hearing me clearly. I'm happy to be here, and thank you, my previous colleagues, for the amazing presentations you just did. And I'm going to start my presentation. One second.
While the partner is uploading our sharing the screen, I'd like to congratulate you, Dr. Mahir, for great project. He presented his poster recently at the conference, actually yesterday, at the APTA Michigan Fall Conference. So congratulations here. Go ahead, Dr. Fatima, when you're ready.
Okay, is my screen sharing right now?
Yes.
Okay. Sorry for the delay. So I'm presenting on the topic of multi-element care transition models, a proposed educational module. So our learning objectives for this session will be to evaluate the importance of effective care transition, and to describe the principles and components of multi-element care transition models. We will also be, we're going to be identifying best practices within each model and understand how these practices can be applied. And finally, we're going to propose an educational module for healthcare professionals. I'm going to try to make it short and sweet as much as I can, and I hope that you enjoy this session. So for a start, I had a case for it to be a bit of an interactive session, but I'm going to skip it for the sake of time. You will find it in the presentation in the archives of the fellowship. Starting our presentation. So the National Transition of Care Coalition defines transition of care as the movement of patients between healthcare practitioners, settings, and home as their conditions and care needs change. So it's a straightforward definition. Transitioning patient from one setting to another is a particularly vulnerable time. Safety lapses can result in negative clinical outcomes, preventable adverse events, for example, drug-related errors, and also avoidable hospital readmissions. Nearly 1 in 5 Medicare patients discharged from a hospital, there are approximately 2.6 million seniors, are getting readmitted within 30 days at a cost of more than 26 billion every year. So they are getting readmitted for unnecessary causes due to lapses in the process of care transitioning, as we're going to see. So among the most common causes of preventable readmissions are inadequate care transitions planning, or communication failures, or delays in scheduling post-hospitalization care. To help address these issues, the CMS has launched what we call the Partnership for Patients in 2011. It had the aim of reducing hospital-acquired conditions by 40% and reducing readmissions by 20%. One way that the Partnership for Patients attempted to decrease readmissions was through the Community-Based Care Transition Program. So the Community-Based Care Transitions Program was created by Section 3026 of the Affordable Care Act, and it aimed at providing a framework for community-based organizations to partner with hospitals to address the needs of high-risk Medicare beneficiaries. So it tested models to improve transitions of beneficiaries from the inpatient hospital setting to another care setting, and to improve quality of care, along with the other two factors, which are reducing readmissions for high-risk beneficiaries and to document measurable savings to the Medicare program. So we're going to start describing what are multi-element care transition models. So the National Transition of Care Coalition considers the following 7 key elements as essential for safe and seamless transitions. So these 7 key elements are what we should find in any care transition model. There are different types, as we're going to see, but these elements should be the standard of care. So these elements are transition planning, communicating and transferring information between providers, follow-up care, and medication management. We have healthcare provider engagement and patient and family engagement. And lastly, we have shared accountability across providers. So this last element emphasizes that when we transfer a patient to another care provider, it doesn't mean that we are forgone of any responsibilities for these patients after we just referred them. we still, after referring our patient, we still have a shared accountability to ensure that their conditions are being managed according to the best practices. So multi-element care transition models are variable. We have the transitional care model, we have care transitions intervention, we have better outcomes for older adults through safe transitions, and we have project re-engineered discharge, and lastly, we have the chronic care model. And I'm sure there will be more and more models out there in the literature, but these are the most famous one, and we're not going to be covering all of them. We will just be giving an overview of the first three ones, which are, I believe, the most popular, or the one who had more evidence throughout the years to back them up. So talking briefly about the transitional care model, it was developed in the 80s, and I believe it is one of the older models, or it has been there for a long time, long decades. It was developed at the University of Pennsylvania School of Nursing by a team led by Dr. Mary Naylor. So it's a nurse-led intervention that was designed to improve the outcomes of chronically ill older adults who transition from hospital to home and are at risk of readmission. The model is implemented through the use of individualized, multidisciplinary, evidence-based clinical protocols that help to prevent decline in health and reduce 30 to 60-day hospital readmissions. In addition to reducing rate of readmission, the TCM also aimed to enable patients and their family caregiver to manage their conditions themselves. So the core components of the TCM are 9 components. You can have your time and check them out after the end of today's presentation, but they are aligning with the 7 previously mentioned key elements that the National Care Transition Coalition recommend. We have medication management, to risk assessment, to screening, and all of these important factors. Moving along to the next model, which is the CTI, the Care Transitions Intervention. The other name that we hear for this model is the Coleman model, due to the name of the Dr. Eric Coleman, who developed the Care Transition Intervention in 2002 to improve continuity of care across care settings and providers. And it is one of the simple but yet highly packed by evidence type of models. And we, if you go and read about the community-based care programs, you would find that it was one of the 2 models that the CMS have chosen to be the best evidence for transitional care from hospitals to other settings. So the CTI is multi-component, is a 4-week, low-cost, low-intensity self-management program. And it is designed to provide patients discharged from an acute care setting with the skills, tools, and the support of a transition coach to ensure that their health are managed and their needs are met. So it targets patients aged 65 years and older who often have acute or chronic health conditions. And it has 4 pillars of care. There are medication self-management, dynamic patient-centered health record, primary care and specialist follow-up, and knowledge of red flags. So there are 4 in comparison to 9 for the TCM, but you will find that they are interlinked, and they are also part of the 7 elements that the NOTCC recommend. I've just mentioned them, and we're going to go for the final model, which we will be talking about this in this session, which is the BOOST, the better outcomes by optimizing safe transition model. Project BOOST is a multi-centered quality improvement transitional care program that was created in 2008. So it is more of a recent model in comparison to the CTI or the TCM, and was developed by the Society of Hospital Medicine to improve care for patients as they transition from hospital to home. And its objective is to reduce 30 days readmission rates and to improve provider workflow and reduce medication-related errors. The model involves tools and resources to identify and manage patients who are at high risk for readmissions, with a particular focus on older adults also. So the Boost toolkit is similar to the components of the TCM or the pillars of the CTI, but they are more detailed, and you can also check this slide after the end of today's session to check the toolkit in details, but it also ranges from medication reconciliation to patient risk assessment and the whole general theme of follow-up care and shared accountability. Okay, so lastly, in this part of the presentation, we'll be talking about differences or commonalities between the multi-element care transition models. Here in this table, you see previewed 6 models. We talked about the first 3, the TCM, the CTI, and the better outcomes for older adults, the Boost. You can see marked by red that the 3 models are very similar. There are, like we just previously mentioned, they share the same components. We find minor differences in areas of high-risk patients identified. The CTI and the Boost, they also have identification for high-risk patients, but it is more different than the TCM model. And we see that the CTI and the TCM are very similar regarding home visit and follow-up phone calls in comparison to the Boost. But at the end, you see highlighted in green that the 3 models all reduce hospital readmission, they reduce overall healthcare costs, and they have backed evidence of improving patient outcomes. We're going to be briefly talking about facilitators and barriers to implementing these models. We start by the TCM. The facilitators were found to be tailored care targeting a specific patient population and high level of institutional leadership support and high level of frontline staff buy-in. We also find the barriers, limited patient receptivity to TCM interventions were a commonly cited barrier to implementing this model, and insufficient communication between providers and service coordinators, and lastly, limited access to patient data due to lack of electronic health record interoperability between service facility. So I want you guys to focus on 2 things here. We have institutional leadership and high level of frontline staff buy-in. We will find these to be facilitators in the whole model, in all types of models. And we will find that ineffective communication and limited patient receptivity also to be a common theme as a barrier in implementing any type of care transition models. We also see here for the CTI, the Alamin model, facilitators, still leadership support, dedicated transition coaches, strong project management, and frontline staff commitment. So it's very similar to the facilitators of the TCM, but for the barriers, we find limited funding and lack of dedicated transition coaches and insufficient executive leadership support as one of the most common cited barriers. And finally, for the Boost model, for the facilitators, we find individual physician mentoring sessions, and also very importantly, establishing expectations that were small in scale, but realistically attainable. And active patient engagement practices and teamwork exercises, these were among the facilitators. And for the barriers, we find lack of funds, again, inadequate staffing or insufficient executive leaderships, and finally, limited frontline staff buy-in. This is the final part of today's presentation, and it is the aim of this small talk was to propose an educational module. So the primary objective of this initiative is to disseminate knowledge and best practices related to transitional care on a global scale, with a specific focus on healthcare practitioners operating in low resource settings. The aim is to create an educational module that will be recorded and made available if was successful online in the Telegeriatric Research Fellowship Archive. By doing so, we aim to contribute to a quality improvement project that enhances the quality of care provided during patient transitions and ultimately improving patient outcomes, particularly in areas with limited resources. So this is basically a preliminary educational module that we envisioned to how we're going to be talking or teaching about transitional care. So it's a nine-part module that starts by introduction to transitional care, where we find that the incorporated teaching methods will be a recorded video lecture, group discussions, and interactive sessions. And we also gonna be assigning readings of relevant research articles on the topic of the first topic, which is Introduction to Transitional Care. For the next six topic, I'm sorry, they're not 9, there are 7. So the first one is Introduction to Transitional Care, and then we have 6 topics remaining, which are going to be divided into 2 parts. Part 1 is overview of multi-element models, and that talks about the TCM in depth through interactive workshops, group discussions, and case-based learning, to also assigning reading and case studies, and even giving on hands-on practice for whoever going to be deciding to take on the educational module. The CTI will come next, and then the boost at last, and then we going to move into part 2, which is called From Policy to Practice. So learning about all these type of models will be very beneficial, but at the end of the day, because not all of us are currently practicing in the state, and some of us are aware of the condition back home in our countries, and how it would be very difficult to implement these type of best practices policies blindly to our local settings. So it would be very beneficial in the educational module to have a tailored part that is targeting from policy to practice, and it will start by comparative analysis of all of these models, so that we can basically take the parts that are going to be relevant to the local settings where we want to basically apply transitional care, and it will also be interactive through interactive workshops and case-based learning, to assigning case studies presentation and giving in hands-on practice. And the next topic would be Introduction to Quality Improvement, Audits, and Root Cause Analysis, which is very important, so that in every setting we know exactly what are we deficient in, and then we can know how are we going to tailor our readings and our studies and our knowledge to the setup that we are in. And it will also use the similar type of interactive hands-on approach. To lastly, the final topic in the module will be implementing multi-element models. And hopefully at the end of this education module, if the proposal was accepted, and if it got successful, is that every healthcare provider from all around the world will be having this easy to access online course, and will be provided by the knowledge, but also by the skills of how to implement this knowledge to whatever setup or whatever setting that they are in. And thank you. I hope that you had a great time, and I will leave this part for questions if anyone has a question or feedback.
Thank you so much, Dr. Fatima. It's a great presentation. Excellent point, excellent area to share. It's an important topic, because when you work at the hospital, nowadays the tendency or the approach is to minimize the admission. One way is the hospitals will be penalized if they have a lot of readmission, especially in certain conditions like congestive heart failure, for example. So they are working hard to make sure the patient is discharged home or to other facilities safely, and if possible to manage the patient outside the hospital instead of the patient returned to the hospital because they will be immobilized. Thank you.
Thank you so much, Dr. Fatima. That was a very interesting presentation. So this concludes our presentations for today. I would like to thank Dr. Nader for the great opportunity and thank all the presenters for today. And I hope you guys benefited from all the presentations. Now it's time for project updates.
Anyone with any updates as far as I think that Dr. Here is going to present next week in California.
السلام عليكم.
Hello, السلام عليكم. Go ahead, Dr. Isra.
أنا حابة جديد أعمل application on chronic kidney disease for targeting the patient of chronic kidney disease. لسه يعني أداب هبدأ وإن شاء الله I will keep you updated about the app.
So you can contact Amal and see if you want any technical support. Or
Yeah, I contact Dr. Amal.
Like,
Contact Dr. Amal before and she helped me a lot.
excellent. So that's great. Thank you for the update. So, thank you, Dr. Isra. Anyone else with other updates? Any questions? So for the newcomers or for all of you, I just want to share with you that we can use some of the previous videos from other fellows who did their interviews and successfully went through and got accepted. So if you go to the app, you go down, you will find some of the videos. You can see all, or you can go to residency. You can search for mock interview, for example. We have some of the old videos, but we have other videos that are collected. So some tips you can find on these videos. And in the past, some of the fellows also shared their tips. So these are some of the available resources for you guys if you want to see. I know it's the time for interviews nowadays, and I wish you all the best. So if there's no questions or any comments, I'd like to thank you so much, Dr. Amal, and your team, all the presenters and all the attendees from today's meeting and in the future who will watch the recording. I'd like to thank all of you. Thank you, and I wish you all the best. Have a wonderful day or night. See you next week. Assalamu alaikum. Thank you so much.
Thank you so much, Dr. Nader. Assalamu alaikum.
Thank you so much, Dr. Nader.
Thank you so much, Dr. Nader.
Thank you.
Thank you, Dr. Nader.
Thank you so much. Have a wonderful day.
Thank you, sir.
Thank you. Wishing you all the best.
Thank you, sir.
Thank you, Dr. Nader. Have a great day.
Yes, thank you.
Thank you so much, Dr. Nader, for the opportunities.
Always, thank you. Thanks. And you, I know you did a great job. So, thank you.
You're welcome. It's my
You know,
pleasure.
by any chance, the team leaders, if they have a group, WhatsApp group, you can send me the list of the leaders and if there's any update. people in the
I think
leadership?
there was a WhatsApp group created by Dr. Nafisa, but not all team leaders joined that group. So I can ask all team leaders to join that group.
Or
And
is
I
there
think
kind of
you're already added to that group. I believe so, but I will check.
Okay, I will check my WhatsApp. That. Thank you so much. I
Okay,
appreciate
you're
it.
welcome.
Dr. Tanya, go ahead.
Hello,
Thank you,
Dr.
Dr.
Nader. How are
Nader.
you?
Thank you, Dr. Have a wonderful day.
Thank you so much.
Thank you, Dr. Assalamu alaikum.
Yeah,
Go ahead,
thanks
Dr.
so much, Dr. Nader.
You're
That's
welcome.
okay. So, Dr. Nader, how are you doing?
I'm doing great. Thank you. Go ahead. How are you?
Thank you. I'm just confirming again about the grand round, internal medicine grand round spiral. We're not able to access the link. If there is any possibility, because previously there was every Tuesday there was a link with the material or the topic that is going to be
So when you
presented.
go to the app, you click on this, it doesn't take you. And if you go down before the, this is supposed to be
This is only what I'm able to see. So I'm not seeing any link or anything to be able to access.
This is the only thing?
Yes, these are the only.
Can you scroll all the way down?
Like, yes, when I go down, it's just that part, but there is nothing other than that. I can't see like any more information.
So I will update the app. It's supposed to be the same link, but I'll update the app.
Okay, thank you
Thank
so
you.
much. I really appreciate it.
No problem. Thank you.
And another question. Is there any possibility to act to have someone who work do you practice out of Sparrow, or how we are going to explain this in the interview? Like if we have access to attend the grand round in the interview, if we have a question regarding that, how we are going to approach this?
It's available to the public, yeah. So it's a virtual. So you will mention that you are with MSU TGRF Research Fellowship, and this is give you a permission or an access to the video meeting as far as the grand rounds for the neurology, also the grand rounds every 2 weeks in internal medicine. So you are a member of this group, so you have access.
Okay.
Thank you.
Thank you. I appreciate it.
You're welcome. No problem.
Have a good weekend.
You too. Thank you. Have a good day. Assalamu alaikum. Assalamu alaikum, everyone.
Wa alaikum assalam.